understanding, or did they have someone to cook for them, and all of these things. And so if we can somehow help bridge that return home, we could also help, but in a way that people understand, right? That it's important to have your nutrition and continue your physical therapy and all of these things. 75% of readmissions are preventable, but 75% of preventable readmissions are a result of miscommunication. The mean charge per stay for an uninsured patient is $22,161. For a Medicare patient, it's $38,320. Reducing Medicare and uninsured patient readmissions by 1% in Texas would save us $440 million. And this data is not brand new, so it's probably more than that now. So Joint Commission also has requirements that we have to answer to regarding communication. When providing care, treatment, and services, we have to identify their oral and written communication needs, including their preferred language. And like I said, document that. We also have to document that they communicate in a manner that meets the patient's oral and written communication needs. They also respect the patient's right to receive information in a manner that they understand and provide it in a way that is tailored to their age, language, and ability to understand. The medical record must contain information that reflects the patient's care, treatment, and services, including their communication needs, language, and the discussion of their health care. The hospital respects, protects, and promotes the patient's rights, and that includes the right to effective communication. So these are all mandates that this has to be done. So the Affordable Care Act also addressed health literacy. And in the beginning, there were grants available for health literacy research and to address health literacy. As we know that some of that is going away, and we don't know what really the future is going to be with the Affordable Care Act and health literacy in general. But I was happy to see that it did address it, and that there was a call out for the need for plain language and effective oral communication throughout the ACA. And that we recognize that with the Medicaid expansion, many of the Medicaid patients were going to have low health literacy because they'd never had health insurance before. So how many of you guys had interactions with patients that either didn't know how to use their health insurance once they got it, didn't know they had to pay their premiums, and so they would show up thinking they had health insurance, and then they wouldn't have health insurance? So there was a lot of issues when ACA went into effect. We didn't expand Medicaid in Texas, but there still are a lot of patients that are seen in the federally qualified health centers that have issues with health literacy. Sorry. So bottom line is money, right, when we talk about healthcare. So low health literacy costs because a lack of preventative health care or overuse of emergency services or longer hospital stays or the inability to follow treatment instructions or hospital readmittance is all going to cost in the end, right? So it's about $7,500 more per person per year. So think about how much you spend on your health care costs right now. Do you want to spend $7,500 more per year? And even if you're not the one that's, using the services and being charged the $7,000, it may be someone who can't pay that, and so then we're paying for it with our tax dollars. And then it's about $238 billion annually in the US that we're spending additionally in wasted health care from having to repeat services or readmissions, all of these things. Also, HCAHPS scores. We all know that we're rated, or we now will, consumers, now that it's more of a consumer market, will be looking at our scores in terms of patient satisfaction. And so we want those to be good, right? Because we don't want them going to the hospital down the street because ours aren't good, and they look and they want to see people like me, and they want to get those referrals when they look. So we do know that it's data about the patient's perspectives of care. It allows objective and meaningful comparisons between entities, and it's a public reporting system that incents us to do better in terms of quality of care. And then it also provides transparency and accountability for return on public funding if you're a publicly funded hospital. So when we look at health literacy, so if we help people understand their health care better, your HCAHPS scores actually increase. So just a 5-point increase in people's perceptions of how they're understanding their health care will increase their scores that say that they feel that you as an entity will keep their medical records private, that they received high quality medical care, and then also it will decrease the scores that they think you would hide something from them if you made a mistake. So these actually just came out, and I thought it was interesting. I wanted to share these with you. How well, these are done by AHRQ, and it's a measure of how well providers are communicating with their patients. And I thought it was really interesting because if you look, the green is actually the good. So we're getting about a B or a C right now on how we're communicating with patients. But I started thinking about this further because I was like, that's not what I see out in the community. So this survey is administered with people who are already in healthcare or already at the hospital. So you have to make some assumptions about that. They probably have health insurance. They probably knew somewhat how to navigate the healthcare system already to even be there. And so they might have a higher level of education and literacy than people if they went and surveyed FQHCs or they went out in the community and did surveys. So I think we have to interpret this with a little bit of a grain of salt. But it is, it's kind of nice to see in the 70s or 80s for those who are in the hospital. So this one is providers pay attention to your mental or emotional health. And I thought this was interesting because when I was doing my research in Austin, one of the things that I found was if you look at the IOM and NIH tenets of health literacy, a lot of that is not even related to communication or direct communication. It's things like, did I have a shame-free environment? Okay, so if you go to get health care and someone makes you take a health literacy test or hands you a form to fill out that you can't read, all of a sudden you feel shame, right? So are you going to want to go back and be made to feel that way again? So a lot of patients won't go back when they have a stressful experience in the healthcare environment. But I really, so I did focus groups, which I'll show you the outcomes too, but a lot of what I heard from these patients was it was more the mental and emotional part of the experience that was not being met, and that actually counts as part of health literacy. So as you can see on this slide, the scores are much lower than just did I understand the handout I was given or the instructions that I was given verbally. This is discussing medication decisions. Do they let people play a part in their own care decisions? And every time I go to the doctor, I always, know what I am or am not going to do, and I negotiate, if there's anything that is not black or white. But most people aren't going to prepare, for those types of decisions. So if we are expecting people to take certain medications or to change their lifestyle, they need to be engaged in that decision. And you can see that it's pretty low in terms of whether or not they were engaged. So overall, money talks in plain language. We may not, but money does. And all agencies have health implications and increased costs that are at risk when you talk about health literacy, legal risks and sentinel events, quality of care and trust in your organization. You have preventable readmissions if you're a hospital, or joint commission requirements that you have to meet. And if you're a recipient of federal dollars, there's ACA implications and the Plain Writing Act of 2010 that you have to think about. So in my opinion, and also in Dr. Richard Carmona's opinion, health literacy is really the underlying currency of success for everything we do in healthcare. And you know, if you look across the board, if people aren't being successful, staying healthy and well, there's a reason, and that reason to me is health literacy. So how do we craft health literate care? Well, AMA has 6 steps to improve interpersonal communications with patients, and that's to slow down, use plain non-medical language, show or draw pictures. Now, one of my part-time jobs while I was in my doctorate was working with an organization called HeartGift. And what we would do is bring children over from developing countries that needed life-saving heart surgery. And I was their patient care coordinator. And they would come over, and all the services were donated and all of that, but you know, they might not have a good grasp on the English language. So I was there to help them accomplish this. Well, we were at one of our hospitals, and I was so impressed because the anesthesiologist, the physician, and the nurse all drew a picture of the heart and showed, like, this is what we're going to do, and da-da-da. You know, I was like, wow, this is the most health literate care I've ever seen. And so we finish all that. The child goes to surgery, and I'm sitting in the waiting room with the mom, and she goes, how are they going to keep his heart alive when they take it out of his body? Because they hadn't drawn the heart inside the body. They just drew the heart. So you can see how you just never know, and you have to be so careful and ask questions. But on the flip side to that, I teach patients to ask questions, because one of the things I tell them, if you start asking questions, it's going to slow that provider down so that they can't run out of the room, because they're going to stop and answer your question. So I try to prepare people out in the community, like I do my daughter, with writing down your questions, writing down the issues. What is it that you really need to find out and cover in this appointment, because you know you only have 10 minutes. So limit the amount of information provided if you're the provider, and repeat it. Use the teach back method or show me technique. How many of you guys know about teach back? Good. So it's where you have the patient teach you back, but you do it in a non-shaming way, where you say, I really want to make sure I did my job, so what I would like for you to do is show me or teach me what I just taught you. And then create a shame-free environment. One of the drawbacks with teach back is a lot of providers don't feel comfortable with teach back, and so we really need to get them to the point where they do feel comfortable. There's been some research done lately that, you know, teach back was thought to be the be-all to end-all, and providers would say, yeah, I did plain language, yeah, we do teach back, we're a health literate organization, but you truly aren't if you're not meeting all of those needs. So yes, creating a shame-free environment is also important, but also good training and follow-up with your providers on teach back. So quickly, with my research in Austin while I was there, like I said, if they used plain language and teach back or plain language materials, and in Austin they had done a good job with Spanish language. So those were all good, and these were providers that had training before. But what I found is that they weren't culturally sensitive, they weren't creating a shame-free environment, they weren't using teach back, explaining coverages and cost of care. There wasn't easy access, they couldn't get their medication refilled easily, and they didn't have patient-centered care by all staff. So here's a quote. I believe they should be a little bit more polite, because sometimes you get there and you don't know anything, which a lot of us don't. When I'm going to a new medical center, I don't know anything about how to navigate or any of that stuff. And I understand sometimes we're not having our greatest day, so she tried to give them the benefit of the doubt. But this is your job, and your job is to deal with people who come and don't know. So they're going to ask. And so you can see how she was made to feel shame just because she asked a question. So while I was in Austin, I had to go to the dentist, and I had just moved there for my residency, so I hadn't established all of these things. But I had my dentist back here in Fort Worth. And I went into this new office, and they immediately did all my x-rays, and they oh, you need this, you need that. And I'm like, wait a minute, I just went to the dentist 6 months ago. How could I have all these problems in 6 months? And I said, I just want my teeth cleaned. And they said, oh, no, you have to sign this contract before we're going to clean your teeth. And it was for $2,000. And I said, no, wait, take a step back. I want the answers to these questions. And the hygienist said to me, I'm not going to argue with you. And I said, then you are not going to treat me. And I got up and walked out. But then as I was leaving, I thought to myself, how many people sign that contract without questioning? So again, shame-free environment. This is another patient that had just had her baby, and she thought that the IUD was part of the whole baby package. So the last time I came to get my IUD, I thought it was still part of the benefits. So I went over there to the cashier, and she said, well, are you going to pay now, or what are you going to do? And I said, well, nobody really informed me that this would have a cost. And she snapped at me and said, everything has a cost. Nothing is free here. So it was a really spiky attitude, and I was very embarrassed. And she didn't deserve that. She, like a young mother that's trying to, do the right thing like all of us. So it was really interesting when I did my focus groups hearing about the experiences. So quickly, we're going to do a little plain language test here. So what would you say for benign would be the plain language word? Good. Not cancer. Daily? Every day. You would be surprised how many patients don't understand what daily means. A negative test. It's normal. That's a good thing, right? But if we don't explain that, people may think I have a negative test. That's bad. Prevention. So we're going to stop something from happening. We're going to do preventive care. Hypertension, high blood pressure. So I've had a patient say to me, well, I have one medication for hypertension, and I have another one for high blood pressure. And you're like, wait a minute, are we taking too many medications? And then oral medication. You take it by mouth, right? So just some quick studies. They told me I could go 5 minutes over, so I hope you guys will indulge me. Some quick studies, but the bottom line is when they did these focus groups with these patients is that it showed that programs are needed for in-person education and or alternative modalities to access information, because education materials are out there, but they're difficult to access and understand. So we need improved communication because it improves, in this particular study, maternal and infant health status. Now, I'm doing a study right now with Meals on Wheels of Tarrant County, and we're looking at the communication needs for homebound seniors over age 65. And I haven't written up the study, and it's not completed yet, but just the feedback I'm getting from the people who are going into the homes is that, yes, there's tons of materials online for seniors, but for this particular group, she's like, you have to make it so basic, like 2 words, a picture of a plate, just all of it's so much less than what we really think people can understand. And believe me, when I'm changing things to plain language for different entities that ask me to do it, I'm like, You guys really don't understand how little people can understand. So in this particular study, and we all know that infant mortality is the marker of the health status of a population. So it's a national priority to reduce preterm birth. And what they found in this particular study, and I'm a firm believer of, is that we need community-based programs. So you'll know, I don't know if it's on the program or not, but I recently became a community health worker instructor because I firmly believe we need people out in the community helping people navigate their own circumstance to improve their health or to stay out of the hospital when they've just gotten discharged. So basically, to me, it's the research translation bench to bedside to curbside. I love that they added that in this study, because curbside means in the neighborhoods where people actually live. And it needs to be culturally sensitive, health literate, and people need to be able to implement it in their homes. So I also have studies on dementia. So what I kind of wanted to show you is it doesn't matter what the diagnosis or what the patient. Every diagnosis, every patient, there's issues with health literacy. And I'm just going to run through these real quick. But the main thing I wanted to show you is that the high rate of unmet medical care needs that arise from low health literacy. So this is both in dementia for the patient and the caregiver, because this caregiver can't take care of their own health because they don't have the information they need to take care of the patient's health. But if we could help them to do that, we could prevent hospitalizations, improve quality of life, and lower the cost of care at the same time. In this particular study, it's needed in multiple languages. It needs to be culturally competent. We need to look at the fact that these information sources need to be readily available, they have good access, and that they are health literate. And this is just a real simple tool that I use for speaking in a culturally competent way. But basically, it's using open-ended questions to get from that person how they interpret their diagnosis and how they're dealing with their diagnosis, so that you can help them from where they're coming from versus dictating something that is totally unrealistic for that person to do. So here's a quick example. When I worked with the Medicaid waiver program, I went into a Hispanic home where a woman was a double amputee and she was bedridden, diabetic, and I was working with her granddaughter as a translator, and we went and we looked in the refrigerator. And there was all these fruits and vegetables in the refrigerator, but they were in the wrappers. And so I looked, I'm like, what's going on with the fruits and vegetables? And they said, well, the dietitian at the hospital told us we needed to buy more fruits and vegetables, but we don't have any idea what to do with them. I was like, oh my God, so I'm constantly like, health literacy. So we helped them decide to make a soup, which was a culturally competent menu item for them. And so they were able to use those vegetables in their refrigerator. So just using those open-ended questions. What I was going to say from this one is the way that we provide information, unless it's health literate, it will disable, discriminate, and apply barriers. So we think we're helping, and we're really not. So just to show you with the provider training outcomes that I've done, that when you give health literacy training, it does, and these were people that already had training before, but it still improved with the trainings. And then they couldn't even define health literacy before this training, and they were able to afterwards. And you notice that patient satisfaction goes up when you incorporate health literate practices. So for most people, medicine is a foreign country with its own language, customs, and mores. Our job as providers is to translate this alien world for them to help them acclimatize and hopefully thrive. So my call to action, and these are just some of the things I do. I've mentioned them throughout the talk, so I'm not going to go over them, but you're welcome to ask me more later after this talk. I also had legislation in both sides of the Texas legislature this session. It didn't go through. We got it all the way to the floor of the House, but because of all the other healthcare stuff that didn't get passed, it died. So we'll have to try again in 2 years. But in the Healthy People 2030, this is my call to action for you. Right now, they are still considering including health literacy in Healthy People 2030. I would love to see that happen. You can publicly comment until September 29, 2017, and the link is here, but I'm sure you can look it up online. But go online, tell them how important health literacy is and that it needs to be in Healthy People 2030, because we need health literacy to be funded in order for it to exist and to be recognized. And that was what my bills would have done for the state of Texas, was help bring it to the forefront in Texas. So lastly, I don't think we have time for questions. 5:08, I hit it right on the mark. But you're welcome to come speak with me afterwards. And my contact information is here.
It's great to hear that. Thank you. Thank you so much for those reminders. There's all kinds of stories we have about, we talk about health literacy and cultural competence.